All right, class, today we are going to be working on a short leg cast. What you see here are your scissors that you will need. We have a 4-inch stockinette. This, of course, can be 4-inch, 3-inch, 2-inch, depending on the size and habitus of your patient. Today we will be using the 3-inch. There are cast pads, cast padding. Of course, then we have cast tape. We have a water source of some kind. We also have a saw. One other item that we will need for the short leg cast to do it appropriately would be a cast or a foot stand. This particular stand is adjustable, and we'll talk a little bit more about that when we do the casting. So as we prepare for our short leg cast, there are a few things that we want to make sure we have ahead of time. Obviously our stockinette, so we will want to again measure from the bottom of the foot, back behind the heel, and up, right up above that tibial tubercle. All right, more is always better, or fine. So we'll cut that cast stockinette. All right, thank you. I'll put that to the side. This is a 3-inch stockinette, but before we get started, one other thing that I like to do is position the patient, and that comes with using our foot stand. So if you notice, my foot stand is not equal with where her leg is. So I will want to make sure that her foot is on it, hold it down, and I do want her to be at a 90 degree, and I'm going to have her scooch forward. It can be very uncomfortable for a patient in this position, especially if they have a fracture in this area. But this is considered neutral position, and this will allow the cast to go on nicely. It'll also make sure that the cast for the ankle is in good support for the ankle. Obviously, if a fracture is up higher along the mid shaft, this is still a concern, but you want to make sure that it has been reduced. So you'll want to take pre and post reduction pictures with x-ray to make sure that it has stayed reduced. All right, so I'm going to have you lift your leg now, just slightly, and we will place the stockinette on. Stockinette should always feel somewhat comfortable to the patient. It should never be too tight, and it should not be too loose. Now to work this stand, I'm actually going to place her heel to the edge, and if you notice, the stand is underneath the stockinette, so the stand is between her and the stockinette. To remove any types of lumps or bumps, I'm going to just place a small cut here, and then we can always overlay the stockinette. But I don't want a bunch of folds in that area of high bend. Okay? So really just, you're able to manage this however you feel most important. Alright? That hole there is fine. We will cover it with cast pad. So right now I'm going to grab everything that I need. I'm going to go ahead and grab the cast tape, the cast padding, and some gloves. All right. So I have some used pieces here that I just want to try and use up. I'm a firm believer in using what you have. If you want to come in closer, we really want to make sure that we're taking a look at exactly where the foot is. We've got our 5th metatarsal here, our 1st metatarsal here. All cast should start at a diagonal along that line, all right, so that her toes, when I fold up, will be nice and free. Don't ever really want to come to this point, so you always want to be at the base, or at the head of that 5th metatarsal, and that way then you can have a nice nice coverage without causing too much pain. So again, we're just kind of wrapping here. And I'm using as much of my leftover as I can just to kind of pad areas. Always just knowing where I've laid cast pad before. You could do a figure 8 at this point. Again though, you don't want a lot of material along this way. Keep in mind I'm still rolling, so I'm rolling it, right? I'm not putting it on like this, all right? So we will go ahead and shorten that a little bit. I always like to ask the patient too if they do plan on using a knee scooter, and the reason is because I will want to pad a little bit more in this area, and that's just kind of a nicety. Keeps your patients coming back and happy. A lot of individuals too will cast at an angle right about here, and the reason is that then that calf muscle does not get pinched within any areas. So she's going to have a knee scooter, so we'll go ahead and give her some thickness along this area here. And I usually use just about three pieces or so, and I will lay it down this way, and that way that shin is protected. And then one more across here. Always make sure that you've got the holes out of the way that you need, such as along the heel. And this cast tape is great because it allows you to just kind of mold it how you need it. Got one more spot here that I see is kind of thin, so we'll just cover it up. All right, Juliana, how does that feel? Good? Okay. All right. Now at this point in time, I'm gonna put on my gloves. This is not sterile technique, so any pair of gloves will work. However, this is all that I have today. I do have 2 3-inch cast tape here. 2 things I would like to introduce to you is always communicating with the patient to stay at that 90 degrees. Women have a tendency, their legs have a tendency to go in. Men have a tendency to externally rotate at the hip. So you always just want to check your alignment as you're going through this. Keep in mind the cast tape works by getting it wet. Once it is wet, it starts the chemical reaction. It will warm up, so you always want to let the patient know that it will get warm, but for the most part, it's not going to burn them, all right? I usually try and use the same cast tape. If you are at a pediatrics, they have beautiful, crazy colors. We do not have that today. However, I have 2 that I do not know. I know one's pink. I don't know what the other one will be, so it'll be a surprise. But really, 2 cast tapes is enough to be able to make sure that you're getting a good casting. I'm going to pop this open. Always have those gloves on. I'm going to go ahead and grab some water at the sink. Just enough to get it wet. And then I'm going to just squeeze it out. I don't want a lot of water in this cast tape. Alright? Again, it's very, very malleable. What you will find is that some of the colors may set up earlier than the white or things like that. If I'm not mistaken, I think black usually sets up quicker than any of them. Again, I find that head of the 5th metacarpal, and in this case it's just a little bit down. I want to make sure that she is at her 90 degrees. And remember, I'm rolling the tape on, all right? So it's a roll. As I come up, I don't want to get too tight, so I will release some of this here, the cast tape, to make sure that I am not pulling too tight, all right? Then I'm going to come up, and I'm going to work on my figure 8s. If you get a fold, it's okay. We can work on that, all right? And as you can see, my tape is just a little bit sticky. All right, and I'm basically just wrapping around the best I can. I am actually going to pull slightly. So you see how there's a little bit of a give? I don't want to pull completely because that means I'm going to cut off circulation, but it's about a 50% pull that I am utilizing. Always ask the patient, how are you feeling? Does this feel too tight?
It feels good.
Okay, does it feel supported?
Yes.
Okay, so supported is probably the best case scenario. Also, if you'll notice, I want to try and wrap about 50% of my width over the previous wrap. Sometimes that's not always the case, but usually that's what you try for. This cast tape is really sticky. So because it's sticky, I'm trying to accommodate by making sure I don't go too tight on the patient. All right. When I come up about this high, you could go a little bit higher, maybe just right about here, but I think at this point in time, for the size of the person, this is a good place to stop. All right. So I'm going to just continue on. And again, just rolling it up and down for the most part. Kind of like a candy cane or a lantern, whatever you want to call it. All right. Now then, I'm going to take a look and see what I have. I have an area here that obviously needs some support, and I'm looking around. I want to make sure she's still at a 90-degree angle for the most part. It's not going to come off my glove. This next one, I am not going to get wet, only because this is going to set up so quickly, and I just want to make sure that we're not causing too much trouble. So at this point in time, I'm going to roll up my stockinette, just because it looks a little bit fancier then, and covers up any of those little areas. It also gives them some padding across the edge. Again, I start at that 5th metatarsal. I'm not wanting to go too far up because I want to make sure that she is getting a good set. Staying in position. Now I want to make sure that I'm covering those areas that I may have missed before. And this is actually kind of nice because with the white contrast, you're able to see that I'm getting some of those areas. You'll notice though I'm getting a little thick around the ankle, so really want to go ahead and try and start moving up the shin. Again, I'm just rolling it and rolling it and rolling it. Always just paying attention as to where we are. This is really sticky, so make sure that the patient's pants or shorts or clothing is always away from the area because this is really sticky, as you can see. All right, so I don't want her to go home with this stand in, so at this point in time I'm going to take the foot and I'm going to slide the stand out, and now I'm going to squeeze for positions, okay? Again, we don't hold on to it because now I've got fingerprints. It's a matter of just making sure that that's adhering and keep that leg at 90 degrees. Sometimes you can squeeze this area just so that it will widen it out, or widen it out so that she is not having to have her foot squeezed. And you always want to give them an arch as well. That's always important for comfort. If the fracture was here, I would probably put a little bit of resistance or pressure here just to make sure that reduction stays as well. Majority of the time, lotion is always good to have on board, and you can then just rub it around as well. That spot is just gonna not want to stay. I might be going home with you today, Julia. Again, we're just gentle molds, nothing too crazy. Is it starting to warm up?
Yeah.
Okay, keep in mind it will not burn you, but it will feel just real warm. All right. If for some reason this continues to bother me, I would just cut it off. Okay, that's always an option. Arch support. Kind of keep going back and making sure that we are staying where we need to be. I should got some KY jelly. That would work. Can you wiggle your toes for me? Good. So it's starting to harden, but not completely yet. Again, when you're doing these casting, you want to be able to, when you're not sticky, place one finger down to make sure that there is that space. Obviously, if the patient is very swollen, the cast itself will loosen. That is okay as long as the foot can move just gentle, like movement, dorsal plantar flexion, a little bit of eversion, inversion. But you do not want them to be able to have complete range of motion, all right? So if that happens, patient needs to come back in, cast needs to be cut off, and a new cast needs to be placed. Warming up?
Mm-hmm.
Good. How do your toes feel?
Good.
They were cold before, so.
Yeah, they're cold.
So this is completely hard here. We're still just a little bit soft up here. All right, so you are not allowed to use this cast as a weapon.
Okay.
And please do not place anything down inside the cast for scratching, all right? What I want you to do is, if you have an itch that won't go away, just tap the cast. Also, please do not get it wet, so put a plastic bag up over the knee and make sure that water doesn't go down in there.
Okay.
If for some reason water does go down in there, please, you could take a low hair dryer on low and just kind of blow it across that area. The cotton should dissipate. However, if you find that it's real soppy and wet, just come back in and we need to get you a new cast.
Okay.
The reason why we don't want that to be wet is because his skin can macerate and then break down. Whenever there's breakdown, we now then are worried about infection, all right? And so that is really hardening up nicely. Again, wiggle your toes for me. Good. Always check cap refill. Make sure that those toes are getting some blood to them. And then you can always ask the patient to ice and elevate. Icing for an ankle can be really tough because I don't want ice sitting on the toes for a long time. So what I like to tell people is just place the ice over the cast, and then you can always put ice up above. And as long as we're just cooling the extremity and making sure that that blood's shunting, we're doing the job. The ice is doing its job. But always keep a barrier between you and the ice pack as well. So those are my recommendations. And that is how you do a short leg cast. All right, so patient has returned back and it's now time to remove the cast. You will see that she did a nice job of not walking on it, and it is it's in pretty good shape. You always want to remind a patient not to walk on it. One other thing too is this area here may have rubbed her just a little bit, so we could have remedied that by just placing a little snip here or some moleskin across that area. All right, so just keep that in mind when you're looking at your end product prior to sending the patient on their way. Usually anything that they feel that's uncomfortable, they can tell you that at that moment. So always just ask the patient. For the most part, we're just going to clamshell. So we're going to cut here and then do a 90 or about a 45-degree angle and cut across. And then I have what are called cast spreaders here. These are really nice. You place them in between the two layers. You push and it'll separate it much nicer than having to use your hands. So it will be loud, of course, but we will just go ahead and cut this off. Patient, please understand that this is not an oscillating saw, it is a vibrating saw. This saw should not cut you, but it will warm up, all right? If for some reason it warms up, I just want you to put your hand maybe on your knee so that I know that you're saying stop, because it'll be very loud and I won't be able to hear you, all right? So just place your hand on the knee or put your hand, just give me some sign. Is always beneficial and helpful. All right, we're going to cut right along here, so I'm not going to affect any of the signatures that you have from all of your lovely friends. And then we will cut along this area as well. All right, here we go. Remember, you guys, always make sure that your hand is going to be protected. So if this is her skin or the cast, we're just allowing that finger to cut the cast. We never roll down the cast. We're doing it bits and pieces at a time. All right. I like to put the leg on her leg on my leg just so that I have that control. Some individuals prefer to sit on the table, and that is completely fine as well. Some individuals will like to contort their bodies and allow you to bring the leg up. I find that that can cause more injury to the hip. And so this position is kind of my preferred position, all right? So we will get started, as long as my cord reaches to me. Take a quick break. I'm going to have you just bend your knee a little bit more. Are you comfortable in that position?
Yeah.
Okay. One thing I just want to say is that thankfully the stockinette will catch the blades as well. So as you notice, I'm holding it, and as I dip it in, I notice it releases, and that's when I get a full release between the layers. And so just always know that once you've kind of done a little bit of a plunge, pull back. That way we're not burning the patient's leg. Okay? All right. I'm going to have you come over on this side now. Are you comfortable here?
Yeah.
In this position?
Mm-hmm.
Okay. So.
Are you?
Yeah. Start down there. I'm gonna have you bend your knee a little bit. One thing to always think about on the lateral side is the lateral malleolus is going to be very superficial. So when you place your line, you always want to make sure that you are behind that lateral malleolus. How you doing? So, the cast spreader is great because once you get into the cast, then you'll find that you're able to just push the cast apart. And this is great when you have a very big cast. Obviously, I could probably pull some of this apart, but this is always nice to have, especially if some areas, such as your corners, have not completely released. And again, I'm not diving in and hitting the patient. I'm just basically making sure that we're in between those cast layers. Okay. Good. All right. I'm going to have you turn your leg over. And again, the same thing. And you will see the lowest layer here did not get completely cut. We could go back with our saw, that's fine, but scissors also is an option. Always making sure that the blunt side is to the patient side. I'm just gonna go ahead and continue cutting this material here. Patient did mention to me that she was sweating pretty quickly. And so keep that in mind. Let your patients know that they're not comfortable and they're not beautiful, but they are functional. That's the key. And you may need to remind them a couple times about function versus pretty. Is that okay? That hurt you?
No.
Okay. Once you get under that material, you should be able to just kind of cut it off. Almost there. All right. Her ankle is free, and her calf is free. And then we just want to take a look at the skin, make sure that there were no cuts along the way or burns at all. She had one soft spot that could have been a soft point here. Just note to self for the next time that you cast somebody. Other than that, you are all free. Majority of the time, individuals do not really want to walk on the leg. They will have severe atrophy of their calf muscles along with their flexor muscles. So you'll want to get them into physical therapy soon. You may want to also transition into, like if it's a malleolus fracture, into just a stirrup type brace to help transition completely out. If they're an athlete, that changes the dynamic as well because they need to have a return to sport type of evaluation with an athletic trainer or the sport team doctor. So that concludes removal or placing and removing a short leg cast. I hope this was helpful. Thanks.